Everybody, we're the Healthcare Committee. We are back in session and we are going to take information from Vital. And we are going to start with Beth Anderson. And then you can fill in with the rest of the people that are there as you go along, okay?
Thank you. So can you hear me okay?
Yep.
Great.
We can hear you.
Thank you. Just for the record, I'm Beth Anderson. I'm the CEO at Vital. You all saw me, I think, just last week. I am joined today by Kara Callanan, who is our Chief Financial Officer at Vital, and also Will Dempsey from the Agency for Human Services, who will help cover some of the topics we would like to talk about today about our budget and how we are funded. So with that, I'm going to share my screen. I'm going to try to share my screen. Okay. I'm going to take just a minute or two just to do kind of a little bit of level setting refresher from what we talked about last week. I promise I'm not going to do that whole presentation, and then we will get into the financials. Just a quick reminder that Vital is a Vermont-based 501c3 nonprofit. We have an independent board of directors, and we are designated in statute to operate the Vermont Health Information Exchange, or you'll hear me call it over and over again, the VHI today, which is a network for sharing data. I thought, following on last week's discussion, and because we're talking a little bit about more detail about Vital, it'd be helpful just to share with you who is on our board so you can see the representation we have across the healthcare community. So we have representation from the Hospital Association, from a couple of hospitals, from the Medical Society. We have a name some of you may know, Susan Pasayo, who used to be at AHS, who is retired. We have representation from Rutland Regional Medical Center, Freeman Healthcare. Sarah actually used to be with Green Mountain Care Board. She's now at Freeman Healthcare. Blue Cross Blue Shield, and another medical center who is a practitioner. So we have a nice mix of representation from hospitals, practices, payers, as well as actual practitioners on the board and policy. Just thought that might be helpful information to have as we talk about Vital more. Just a quick reminder about what we do is that we work with healthcare organizations across the state to collect their data, match and standardize it, and make it available for a number of different purposes. At the point of care is a big focus of our work, getting data to providers so they can manage the kind of point of care or at the moment situation with a patient, but also for things like care management and coordination across organizations, for quality improvement programs, public health activities, population health initiatives, and healthcare reform. I'm not going to spend time here because I know we did this last week, but just a reminder so everyone has, and some may not have seen, a good sense of the organizations that we do receive data from and or share data with across the state. So it's a total of 241 organizations we work with. That's not locations, but actual organizations. So it is all of the primary Vermont hospitals, as well as we receive data from Dartmouth. We share data with another hospital in the Vermont-New Hampshire border. We receive data from all of the FQHCs across the state. We work with a large number of independent specialty care practices, home health agencies, nursing homes, pharmacy chains, labs, and state departments, as well as payers and EMS. We do share data on Vermonters with providers across or healthcare organizations across the state. We currently have 98.9% of the Vermonters who we have data on that are sharing their data or have their data being shared with those healthcare providers, which is really great. When we share data, it is with only authorized organizations, and that's very specific to us. So how we share that data is governed by a number of different agreements, I'll call them. One, we have agreements in place with all of the organizations that submit data to us that define how we can share data. We also follow state and federal law, including HIPAA. We have policies in place at Vital that are actually a bit more restrictive than HIPAA, as well as the Appendix A of the state's HIE strategic plan. So we have very clear and specific ways the data can be shared, and we would take those very seriously. And we're very open with patients about that. And I think a really great thing that we do here in Vermont that isn't necessarily practiced in other states that have an HIE operating is we do a lot of patient education and outreach, so individuals can understand how their data is being shared, who has access to it, and also get copies of their records if they want to understand what we have or who has viewed their records. This I thought I'd do. We didn't talk about this last week, but I thought just some interesting information to help give a sense of the volume of work that we have, the data that we are managing at Vital. So for those 241 organizations that are contributing or accessing data in 2024, and for right now I'm talking about for calendar year 2024, we received over 60 million messages. That's healthcare records for encounters that individuals have had. It could be an immunization, it could be a doctor's visit, it could be an emergency room admission. We delivered over 1.3 million test results directly into providers' EHR. So that's where we can say, you're a patient, you sent a patient for a blood test. We are putting that record, the results of that test, right into your system at your practice so you can see it in your patient record. We delivered a little over 23,000 reportable lab results to VDH. We shared over 1 million immunization records with them last year. We enabled access to over 253 immunization histories for providers from within their EHR. So again, that's where I talked last week that they no longer have to go into a special system to get the immunization records, but can query through the BHI directly through the immunization registry and get that data at their point of care. We also have a provider portal, which I mentioned last week, which is that web-based platform that allows healthcare providers to access data that's in the Health Information Exchange. It's a separate system. It's web-based. They can log into it when they're an authorized user. We currently have over 2,700 users at 183 organizations across the state using that data. And in January, we had almost 23,000 chart accesses. And what's really exciting is we've done a lot of effort. We launched a new portal about 2.5 years ago, and we've made really good effort to do a lot of outreach and education for the provider community. So we get, so there's an awareness that this tool is available for them and how they can actually use this tool to support their work. And in the year between December 2023 and December 2024, we saw a 53% increase in use of actual chart accesses each month. So it's pretty exciting results for us. I'm going to now talk about our budget, and just what I'm going to do with the budget is talk a little bit high level about how the budget is set. And then I'm going to very specifically talk about our budget for the current fiscal year. Our fiscal year follows the state fiscal year, and that is how our contract with AHS works. So it'll be July 1 through June 30. So we're in the middle of a little more than the middle of the current fiscal year. The work we do at Vital is really guided by a number of different inputs, but very specifically the state's HIE strategic plan, which is developed by AHS in partnership with the HIE steering committee, and also a strategic framework or our strategic plan at Vital. And I just thought it'd be interesting to share the goals of both of those plans with you so you understand kind of what informs some of the work. So the HIE strategic plan goals are to create one health record for every person, to deliver better health outcomes, to improve healthcare operations, and to use data to enable investment in policy decisions. And then for Vital specifically, our strategic directions are to focus on our customers, to tell our story so organizations know what we do and what's available for them, to be the go-to partner for exchanging Vermont's health information, to build a learning organization, and to ensure sustainability for the organization. Quick context on our budget, and I'll be over these next slides kind of drilling more and more specifically in, but just to talk about our funding sources. So about 97% of our funding for this current fiscal year comes from our contract with the Agency for Human Services. And Will Dempsey is here and can talk a little bit about the agency side of how that is funded and how they think about that contract. But just for context, when we look through the numbers, it's about 97% of our overall budget. And approximately 3% of our budget comes from other sources, which we'll touch on. And each year, our budget is actually reviewed and approved by the Green Mountain Care Board, in addition to Vital's board. Our annual contract with AHS really allows for funding for two types of work, and all two really categories of work. One is maintenance and operations, and that's really the work that we do at Vital to operate the HIE day to day, to make sure data is flowing in, to make sure the data is flowing out, to pay the licensing fees for the software we use to operate the HIE, to get the data to public health, to do education for providers and training so they understand that what they can use Vital services for and why it's worth participating, how to use the portal, how to find things in the portal. It's for onboarding new clients. It's for making that provider portal available. It's for getting results out into the community, to the providers in their EHRs. It's to do patient matching. So we're having really one record for every Vermonter, and it's to manage patient consent. There's a lot more that goes into that, but just to give you a sense of what kind of the day-to-day operation looks like, that's what falls into maintenance and operation. And the next component we look at is called design, development, implementation. And just to be clear, these are kind of tied to CMS, Centers for Medicare and Medicaid categories for how they do funding, which we'll talk about, but just why we use this language. I think it's helpful to know. But so that design, development, and implementation, or DDI, is really to enable the creation or implementation of new functionality and capabilities. And so that's project work we might do each year, and can include things like building new interfaces to get more data in or out of the HIE. It could be to integrate new data types into the HIE or deliver new functionality for providers or others to have access to the data or use it in different ways. Specifically for this current year's or the FY25 contract, I'm going to talk through what some of the DDI projects are that we're doing. You heard a little about some of these when I presented last week, but just to give you a sense of what a development or DDI project might look like. One is developing application programming interfaces. That's a way to use some current technologies to allow the VHI data to get into providers' workflow, to allow them to query the HIE to get the data that they want specifically and have it kind of in the place that they want to get it. It also allows us to collect more data from more organizations in different ways. We're building new data collection interfaces. So every day I have a team that's working with healthcare organizations to build connections to get more data, new data into the HIE, or to remediate existing connections to add new data or make sure that they're up and running. We have continued collaboration with public health. I know I dove into this a little bit last week, but that's really some of the projects we're working with them on this year, is delivering more of the reportable disease lab results to them in a timely manner, so we can take that burden off of providers and make sure that VDH is getting the information holistically and timely. We are working with the WIC program, the Women, Infants, and Children program, to get them data into their systems. They've been using our provider portal to manage some of their work and have found the data really helpful. It both makes their work more efficient, but it also helps to make the process of getting and staying enrolled in programs easier for the participants. And we're working to automate some of that data collection for them. And finally, we're working to integrate immunization registry data and birth data into the VHI. So it's another example of, well, this will allow providers to have kind of one place to go to get all of the data on patients instead of having to manage access to different systems. We're making some enhancements to our provider portal to make it easier for them to log into it from their system, so they don't have the burden or extra steps of logging in. We are supporting work with Medicaid agency through their data warehouse, as well as the Unified Health Data Space. We're getting data to the Medicaid agency so they can use that to inform their operations. We're doing work to collect social determinants of health data, specifically the Centers for Medicaid and Medicare's, I will get it right, Accountable Health Communities, Health-Related Social Needs Questionnaire, which healthcare providers across the state are standardizing across to do the data collection. So we want to look at ways to get the data into the HIE and then use that data to inform care and care coordination. Both within your traditional care providers, but also thinking about what other needs patients have. We're doing work to support the state's MDAP program, and that's work they have to get new providers engaged in using certified health IT at their point of providing care, as well as then to connect to the HIE. So the providers very specifically that they're looking at this year to work with are some groups like, I'm sorry, Will, you might want to help me here, but some of the behavioral health in particular, where they might be using EHRs that are not certified now, but to get them on more robust technology and be able to participate in data exchange. And then finally, expanding provider outreach. So we have a 2-year designated or really focused project on doing some outreach to get in front of new providers and make sure that we have providers across the state really understanding what data is available and how they can use it to support their work. Then as we look into this year's budget, this breaks down our revenues by the categories of work that we do. So that maintenance and operations that I mentioned, that's keeping the HIE functioning, is about $6.8 million this year. That's a number that will change a little bit year to year, both to account for escalations in salaries and healthcare costs for our staff. Our software contracts often increase. We have annual escalators engaged in them. And as we do each year development projects for new capabilities or new technologies, we may have new costs that become an ongoing cost for licensing or support of that work. For FY25, the DDI work, the development work we have, is about 4.5 million. Well, that's those projects that I just talked to you about. We have some deferred revenue, which is more of an accounting perspective coming in. We have some data delivery services. So this is where we make data available to external organizations, again, who are authorized to have access to other health data for them to use potentially in their systems or for other purposes. This does include some revenue from OneCare, which we are no longer going to be receiving going forward. So that is something that will shift a little bit in our budget, but we do have a few other smaller payers or accountable care organizations that we do work with to provide data. We have notification services. This is where organizations may sign up to get, we work with a third-party partner to deliver event notification. We get some small revenues from that. We also provide some services to hospitals that to help them meet some CMS needs that they need to work with. So it's very specific to some hospital needs. And then we do have some other miscellaneous sources of revenue and interest revenues that kind of make up our kind of overall revenue for Vital. So this chart, I know it's hard to read. I will try to zoom in a bit, but just gives you a sense of what our finances look like for the past couple of years, and then what this year's budget looks like. So that's in this kind of center column here. So overall, our revenue, kind of as we looked at just on the last page, is about $12.1 million for FY25, or it's projected to be $12.1 million. Our expenses are projected to be $12.2 million. I will tell you, when you read this, to look at, it looks like we are going to have a loss, but actually we are not. Some of the expenses we have for this year are monies that our Vitals board designated use of some of our assets to do a very specific project this year, over a couple of years, to shore up some of our infrastructure at Vital to support the work that we're doing. And so that is covering some of the expense. So it is intentionally operating at a loss using some of our assets to support our the growth of our infrastructure and deliver on our needs. It's going to take a minute or two to drill in a little bit to some of our larger expense lines so you understand what they are. No surprise, they're salaries, software expenses, and outside support. So I'm going to start with the software and outside support. On the left are the software expenses, and that's about, in this year's budget, about $2.4 million. And you can see the orange there. So what the designation is in these two charts is the orangey color is actually what would be considered M&O, or kind of the cost to operate the HIE as it is. And the blue costs are more of the costs associated with the development projects or the one-time work that we are doing. So the software expenses are largely focused on the day-to-day operating, the HIE. So that's that almost 2.2 million piece. The outside support expenses, as you can see, some of them are operational, about 1.6 million, and that will include where we might use contractors for certain skills or expertise, where we pay for legal, our insurance, and our cyber insurance expenses are in there, things that are auditing, things like that. But then the bulk, almost $2.3 million of outside support, is really focused on costs for the DDI project. So that's where we need staff to support those projects, where we need outside expertise to support those projects, or we may have some expenses with our vendors to build new things. When we look at our personnel costs, they are almost $5 million. This just gives you the breakdown of what those look like for salaries relative to benefits and payroll taxes and retirement costs. I'm not going to spend a lot of time here, but I will spend a bit of time just talking to you about our structure and the number of staff that we do have. So this is a high-level functional staffing chart for us. We are budgeted for 33 full-time equivalent staff members. We don't have quite that many now. We have a few open positions, but that is what we are budgeted to. We also have one limited service position, and that is the individual that's in the clinical education lead position. That is that 2-year project for provider outreach that I mentioned a few minutes ago. So we have a finance and HR administration function, as well as that also includes our privacy and compliance work. We have a client engagement team that does cover both product management, so representing our products to clients, as well as hearing their feedback and input for how they might want to see functionality different or improvements in some of the work that we do, as well as individuals who work directly with clients just to support their needs, do trainings, onboardings, education for clients. We have an operations team. This team is really has a couple of components under it. One, it's the team that builds the interfaces to get data into the HIE and maintains those interfaces. It is a team of support experts, so they are the ones who monitor our systems and make sure that they're up and running. They take in questions or complaints from any individual who may have forgotten a password or see something in a system that they think isn't right and want to ask questions. And they will also do training and education of clients when they need. We have a terminology coder, so that is someone who actually works on I'm going to leave it at a high level, works on some of the cleanup of data. And then we also have individuals who really focus on the data itself, working with the data, making sure it's clean, doing operational reporting, doing extracts and data reporting. We have an IT team who manages both our internal infrastructure, but also does work with our vendors to oversee their work. We have a dedicated security analyst, sysadmin, integration engineers, individuals who work with the interface team to get the data in, to keep the data flowing in and out of the HIE. Then we do have a project management team because we do have a number of those DDI projects. So we have project managers help us coordinate and operate the work, make sure that we are planning our work and sticking to our plans for the work. So that is what I have. I think at this point I might pass it over to Will to present the AHS piece of the funding, if that is acceptable.
That's fine.
Great.
Well, before we go there, are there any questions on this? None. I have one. On your budget sheet there, you had deferred revenue. It's collected, but it's not recognized. Can you just explain what that means?
Yeah, sometimes, and Kara may want to help me here, but I'll try. Sometimes we have projects that will we have a deliverable across multiple years, and it's just an accounting recognition of that revenue when the full project is completed. So even though we may have completed milestones and delivered a part of the work to clients, we may have done additional work or enhancements in a following year. So that's when we recognize the revenue.
Okay, thank you. Daisy?
Since we're back to the expenses, I know at the top you outlined revenue. Do you know how much your budget comes from the HIT fund?
Will from AHS is here to talk about how they provide the funding to us.
Okay. You okay with that?
Yeah,
Yeah,
I'll wait for Will.
Okay, thank you. We'll go to Will Dempsey.
Thank you.
Will you just introduce yourself, Will, please?
Yes, sir. For the record, I am Will Dempsey. I am the Health Data Officer for the Agency of Human Services. I'll share my screen as well. And we can dive right in, everybody. Okay. Before I dive in, can everyone hear me and see my screen? Okay,
Yep.
Perfect. And feel free to interrupt me along the way if you have questions. I don't mind in the slightest. So I'm going to talk a little bit about our funding, and this is from the Agency of Human Services perspective, just to be clear. So this slide should look timely. So the Health Information Technology Fund, also called the Health IT Fund, is the primary source for the state share that helps to pay for Vital's the costs at Vital, as well as a few other organizations. It's not specific to Vital. It was established as a special source of funding for medical health care information technology programs. It does include Vital and the HIE plan as drivers of the usage of the funds, but it also includes state entities designed to promote and improve healthcare information technology. So there are a couple other programs that use the fund as well. Act 144 of 2024 amended the effective date for the sunset from July 1st, 2025 to July 1st, 2026, and the extension of the fund requires legislative intervention. So it won't have to be extended again until next year. And I did include a link here to the latest report that AHS submitted to the Agency of Administration as required by 32 VSA 1031G.
I'm not sure your link is working in that.
My apologies. I have it open and I can share that on my screen if you all would like, if you have specific questions about the fund.
Could you just send the report to our committee assistant?
Of course.
That would be great. Thank you.
Mhm. I will do that as soon as we are done here. Okay. This is just a continuation. There's too much text to fit on one slide to make it legible. So this breaks down the HIT fund a little bit and how the fund is actually supported. And it uses part of the healthcare claims tax. The tax is 0.99 of 1% of all health insurance claims paid by the health insurers for Vermont members. This is pursuant to 32 VSA 1042B. Within that statute, it breaks it down further. The Health IT Fund receives 0.199 of that 1% of the healthcare claims tax, and this is the source of funds for the state share of the VHI funding structure. I do also want to point out, not all of Vital's funding and their contract comes from, the state share rather, comes from the Health IT Fund. We also utilize public health grants and things like that within our contract with Vital, depending on availability and priority. The general fund receives the remainder of that 0.99 of 1%, and that's 0.8 of 1%. So that flows into the general fund. Any questions on this before I move on?
Thank you.
Of course. Centers for Medicare and Medicaid Services, CMS, utilizes a concept called outcomes-based certification, commonly referred to as OBC. I tried to define every single acronym that I possibly could. If you all find one that I didn't, please feel free to ask. I will happily define it. The VHI, as Beth said, that we use that acronym a lot, which is operated by Vital, achieved its outcome-based certification in 2022. So it's been about 3 years, coming up on 3 years with CMS. This outcomes-based certification ensures that we have substantial federal funding to develop and maintain the VHI. CMS defines these, as Beth said, as DDI and M&O, and I'll get into a little bit about what that means in the next slide. And then for transparency purposes, outcomes-based certification metrics are reported quarterly to CMS, and they're available on our public-facing website. Every metric that we've ever reported gets included on our website. So if you all would like to go see how we're doing, you absolutely can. And that feeds into the calculation that CMS uses for the percentage of the funding that they give us, because it does vary quarter over quarter. This is my last slide. So here is a snapshot of the calculation that's used to determine the funding rate. I don't want to get too deep into the calculation because The accountants would probably be better at describing it than me. But it uses the number of providers in Vermont who contribute or who participate in the VHI rather, who provide services to Medicaid members. So even if they see one Medicaid member, they are classified as a Medicaid provider according to our agreement with CMS. So we're sitting at 94%. In this, you'll see DDI CMS base rate, design, development, and implementation base rate. This is for Medicaid projects primarily. You'll see this in a lot of their documentation where the federal government pays for 90% of the project, the state share is 10%. The base rate for maintenance and operations with CMS is 75% paid for by CMS, 25% paid for by the state. Because the HIE is more than just Medicaid data. The Medicaid population, it is inclusive of this, but it's not the only population within the VHI. So we worked with CMS during our certification process to come up with what's called a state share. And you'll see in the blue highlighted section for design, development, and implementation activities related to the VHI, that is with Vital. As of this past quarter, these were just submitted in December, 84.6% of the costs are paid for by CMS and 15.4% are paid for by the state. And that 15.4 uses the HIT fund dollars. That's the state share. M&O, moving down to green, you'll see is 70.5% federal and 29.5% state. Again, that 29.5 uses the HIT fund dollars. And then I just defined some acronyms and things on the right-hand side on this slide as well. Does anyone have any questions about how we allocate the funding and how we set things up?
No, I appreciate the clarity. Thank you so much. Oh, wait, Daisy, I think maybe Daisy has
In the back of my head is, I hope that you're doing contingency planning for what might happen with those federal funds, because it appears they're significantly behind the success of this program.
Yes, we absolutely are having those conversations, including with Vital.
Great.
Yes, that is a risk that we're very well aware of. Absolutely. Any other
Thank you.
questions? Yeah.
Any questions at all? No. Thank you very much. I apologize that I was not able to be here for most of your presentation. I was looking forward to it, but I will get filled in later. All right, so
One more question.
oh, there is. I'm sorry. I'm behind.
Kara Callahan.
Oh, Kara.
Oh, Kara was just here with me in
Oh,
case you had
yes.
hard accounting questions.
Oh, okay. Well, thank you. And
Thank you.
Of course.
Thank you for joining us today. I appreciate it.
Of course, I'll stop sharing now.
Thank you.
We can